the end of this presentation, we're hoping that participants will be able to identify behavioral health issues related to the older adult population, outline 2 tools used for assessment of cognitive impairment, name at least one evidence-based intervention specific to the older adult population, and discuss how to support caregivers. When we look particularly at the geriatric population in the United States, we can see that there has been exponential growth over the last century. Actually, 1 in every 6 Americans were an older adult, and this is even further going to grow by the year of 2060, when about a quarter of the US population will be in that older adult population. And when we look at the specific health concerns related in this adult population, the older adult population, we can see that most of them have at least one chronic health condition, and many of them have multiple. And in this particular population, about a quarter of them report somewhere between fair and poor health. When we break down some of the chronic conditions, up to 25% of them are living with a mental health concern, most commonly depression and anxiety. And then just over a quarter live with obesity. About 20% are diagnosed with diabetes. 58% of older adults surveyed in a 12-month period had the diagnosis of hypertension. And then we look about more behavioral things. About 9.4% had difficulties with self-care, and 9% of people were currently smoking. And so all of these people are coming to primary care to get help with their current health concern. And so when we think about older adults' experience in the healthcare system, we do know based on quite a bit of literature that ageism does impact healthcare, access to healthcare, and advocacy around healthcare. Yeah, ageism-related complaints actually make up about a fourth of the discrimination complaints to the U.S. Equal Opportunity Commission. And I'm wondering if some of you would mind putting in the chat maybe some examples of ageism in the healthcare system, either you've heard about or that you've witnessed or you think may be happening. And I'll just take a look at the chat. I'm sorry, Maria, that you've had that experience.
And I don't do that old.
Anyone else think of different ways ageism might show up? Older people won't do therapy, so why offer? Definitely a barrier to behavioral health needs, right? And also discriminatory practice about who gets access to whole person care. Thank you, Stacy. All right, feel free to keep putting those in. I'll keep an eye on that chat. Some of the things that I found as examples of ageism is when something is wrong, actually dismissing it as normal aging. So that particular person doesn't get the treatment that's necessary for what is going wrong. Or the opposite, that, something is a part of normal aging and they're treating it like a disease or a diagnosis. And so that person gets overtreated or gets a treatment that they don't necessarily need. Ageist jokes and comments in the workplace, that doesn't make it very friendly or invite commentary by the particular patient or even caregivers that might be caregiving for them. Elderly adults are excluded from clinical trials often, and often you can hear some misconceptions about the expected level of activity for the older adult population that may impact recommendations about physical activity or what they're expected to do right now. The next part is going over some common myths that occur about the older adult population. What are some common phrases or myths that you all have heard about the older adult population? Yeah, younger providers do not have geriatric experience with patients. Experience matters. Oops. So I unveiled some of the common myths about older adults. So one of the myths out there is dementia is inevitable, and that's not actually true. Most older adults are cognitively intact. This population has also been characterized, or the myth has been that they have higher rates of mental illness. Also not true. Younger adults actually tend to have more diagnoses of depression than the older adult population. Some people say that this group is homogeneous in nature, but we actually find that this is a quite heterogeneous group in ethnicity and cultural. And in fact, it's become even more heterogeneous from 1999 to predicted in 2030. It's going to actually have 217% diversity within the older adult population. Another one is most are frail or ill. That's also not true. A lot of older adults have positive functioning health. That in this particular population has no interest in sex or intimacy. Also not true. Older adults have very healthy sex lives and good relationships. And then another common myth is that often older adults are inflexible and stubborn, when we know that personality is stable over time, and often they have the same personality in older adult years than they did in younger adult years, and they don't magically become rigid or stubborn just because they've been aging. And so when we think about integrated primary care and actually embedding a behavioral health consultant, we do see that both PCPs and patients actually benefit from this service. So PCPs reports that the overall care of an older adult population is enhanced, and it increases the likelihood that an older adult will be engaged in behavioral health consultation or behavioral health services. And that's why I'm so excited about talking with you about this today. So what are some of the behavioral health concerns that you have seen in geriatric primary care? And I kind of gave away some of them with the most common health conditions cited on the first couple slides. Depression, loneliness, grief, PTSD, depression, anxiety, isolation, HISD, Ocean's behavior, anxiety, grief. Yeah, all things that can show up in primary care in general. And so I just wanted to add to the list that we already had on the original page, just because we can definitely help with obesity, we can help with poor health, we can help with chronic disease management, we can help with smoking, we can help with self-care. But some of the other behavioral health concerns that show up commonly in the geriatric population is cognitive impairment. So 14 million older adults will be diagnosed with dementia by 2060. So it is prevalent, and this is a prediction. Elder abuse, 1 in every 10 Americans can experience some form of elder abuse. And we're going to go into the first 4 on this slide in more detail later on in our presentation, but I do want to give you a little bit more detail about the other concerns listed on this page. So caregiver distress definitely impacts the geriatric population health. Mental health concerns, right? Again, most common is depression, anxiety, where you can see up to 15% have the diagnosis of depression and 10 to 20% has a diagnosis of anxiety. Now we look a little bit more about fall risk, and considering that 3 million each year are treated in the ED for fall risks, it makes a lot of sense that both elderly patients as well as their caregivers would have quite a bit of fear about someone falling. And so behavioral health consultants can go in and talk with a family and a patient about their fears around fall risk, and also talk with the primary care provider about other things that might be contributing to fall risk, like medication or chronic disease management, and help with those changes. They can also be evaluated for if the current fears are realistic or not, because as we know, fears greatly impact the limitations you might put on someone, and that might impact someone's physical activity or engagement in activity that could lead to less engagement in valued activities with family, friends, and so on. Another thing that comes up in the elderly population is incontinence, with 55% of women and 30% of men in the older adult population having some type of urine incontinence. And I've actually worked with quite a few older adults that have really restricted their going out because they're worried about soiling themselves. And so they don't have family members over, they don't have parties, they don't leave the home. They're worried about judgment. They're anxious about being unclean or being seen unclean. And so working with those individuals about brainstorming what materials they might need to be comfortable, or even doing some cognitive disputation about the thoughts that might be keeping them away from their family, or some value congruent behavior, even if they are having these fears. We can always help someone with sleep. So insomnia is the most common in the elderly population. And so helping someone sleep better. We also know that this is something we have to kind of tease out if someone's having a memory concern, because poor sleep can definitely cause some differences in a lot of things like concentration and memory. Sexuality, right? 2/3 of the older adult population report interest in sexual activity. And so behavioral health consultants can work with them about behavioral interventions for erectile dysfunction, orgasmic disorder, vaginal dryness, premature ejaculation. In this particular population, safety risk is definitely something we should be assessing, understanding that 27.2% of suicides in 2019 were in the older adult population. And then typically the people most at risk in this population are older white men who typically use firearms as their means. So assessing their access to means will be important. The next category here is substance use. So about 1.9% of the older adult population is diagnosed with a substance use disorder. However, about 20% of this population actually misuses alcohol, prescription medication, or over-the-counter medication, and often unintentionally. And sometimes they'll have those effects where medications are combined, and so the tolerance might be different there. So BHCs can come in and talk about their current usage and problem solve different ways to make that most effective for them. And then if you look at the next couple on this slide, life transition, social isolation, grief, bereavement, and mourning, this is truly talking about their social environment as well as their roles and these transitions that occur. So older adults may be going through many transitions in their life: retirement, becoming a grandparent, losing a spouse, losing friends. And some may be experiencing some social isolation around this time, which we know is a key risk factor for depression and later in life. Not only the loss of a caregiver or a spouse or a family member that might be coming on, but grief and bereavement and mourning can be about many different things in an older person's life. It could be about grieving their current level of functioning because it's changed as they gotten older. It could be grieving about a health condition. It could be grieving about a change in role and leaving their job and not having as much contact with their coworkers. So there's many losses that can occur and additions that can occur in a older adult's life that we can talk to them about these transitions. And then, of course, since most of the adult population has one chronic medical condition, often that does become comorbid with mental health concerns. So we can help with addressing the different behaviors that will come into play in taking care of their chronic medical condition, as well as the mental health concerns that might be coming along with them. So if we go back to the first bullet on our slide, we look at that cognitive impairment. It's first good to understand just the different categories of cognitive impairment. And so the University of California, San Francisco Memory and Aging Clinic defines normal aging as normal age-related declines that are subtle and mostly affecting thinking speed and attention. When we go up to the next category, mild cognitive impairment, these are cognitive impairments that don't really affect someone's ability to do their everyday tasks. So like cooking, driving, shopping, and all these other things that they typically do every day. And then we become worried in the dementia category when these cognitive difficulties start impacting the person's ability to complete everyday tasks. So as mentioned on the previous slide, right, it's predicted that 14 million people will hold the diagnosis of dementia by 2060. And so as a behavioral health consultant, it's good to know what dementia is and all the different categories that are present in the dementia definition, right? Alzheimer's is not the same as dementia, but it is a particular diagnosis under the dementia category, considering that dementia is an umbrella term for the loss of memory and other thinking abilities severe enough to impact the daily living. Now, when we're looking at dementia, we really do have to rule out some other things as well. As mentioned before, we need to assess someone's sleep. If it's depression, is it delirium? Is it related to a medication side effect or a medication change? Is it a medical condition such as, UTI or a poorly managed chronic condition that is affecting their cognitive abilities? And a lot of times, this type of assessment is very hard to do in primary care because this much teasing out can be a lengthy process. And so when we are first assessing for cognitive impairment, in order to balance this idea of safety and autonomy, we first need to ask the patient if they are experiencing any memory concerns, what have they been noticing, what do they think about their family members or caregivers' concerns. And then we can go ahead and assess collateral information from family members or caregivers. And so some of the helpful questions that you can ask family members is, what have you noticed about your dad forgetting? Have you noticed any changes in his sleep? Have you noticed any changes in their behavior, such as spending more time in their room or more paranoia? Are they having a hard time operating appliances? And so getting a global picture. But then we also need to kind of look at the ADL, so the activities of daily living. So these are the basic things they need to do to take care of themselves. Lots of hygiene stuff, so bathing, brushing the teeth, dressing, walking, right? Do they need assistance while they're walking? Can they climb stairs? And then we can ask more about the IADLs, which are instrumental activities of daily living. And these are more complex, basic things that someone needs to do to be able to live independently. And so these are categories such as cooking, shopping, cleaning, taking medication, managing their bills. So we're trying to get a big picture of what is going on. And so as you're going along in your clinical interview, behavioral health consultants really need to have an ear for those red flags of when we think about, okay, should we be considering a dementia diagnosis? And so dementia and memory concerns is much more than just I'm forgetting things. Again, it's looking at how it's affecting their functioning. So are they worried about driving because they're getting lost and they can't get home? Are they spending more time in their bedroom? Are they not engaging in activities that they truly used to enjoy with the family? Are they getting confused with what time it is or where they are? What date is it? Are normal tasks that were familiar and easy becoming more difficult for them for no apparent reason? And have these changes really occurred, suddenly, or has it been kind of like a gradual onset? And if it has occurred suddenly, did any type of trauma or a medical event happen around that time so we can get a good picture? So let's say you do the clinical interview and you are, suspicious, you're seeing some of these red flags. What are some of the cognitive screeners that you have used or seen used in primary care? Mocha, slums. Wonderful. Mocha. All right. Yeah, so that's a lot of the ones that I've been seeing used too. There's one more that I want to bring to your attention. So definitely the MOCA, so the Montreal Cognitive Assessment, which is a 13-item questionnaire that's scaled on 30 points and available in 100 different languages. I think in the past couple of years, this has become proprietary, so you must have training in order to deliver this particular assessment and use the data from it. It does take about 10 minutes to administer. And most recently, they actually, Milani and colleagues brought down the cutoff score into looking at particular ethnicities as well as education. And so originally, everyone had the cutoff score of 20, less than 25 would be considered a concern for cognitive impairment. And now they're saying that if someone is white and has less than a high school education level, a 22 is what less than a 22 is what they'd be really concerned about. And then if someone is Hispanic, the original cutoff of 12 years or more of education is a 24. And if they have less than 12 years of education, you're looking for about a cutoff of a 23. And then if someone is a person who identifies as Black, the cutoff for 12 or more years of education is 23, and less than 12 years of education is 19. So you can see without these adjustments, there's a significant difference in the cutoff scores that may have applied some biases within the reading of the MOCA. The second one on here is the RUDOS, and that's the Roland Universal Dementia Assessment Scale, and that's a 6-item scale scored on 30 points. And this was really designed to really minimize the effects of cultural language and learning and language diversity. And so this was prepared with 30 different language using interpreters, just to consider, often providers don't speak the language of the patient and they are using the interpreters. And so this is can be administered in 10 minutes and it has a cutoff score of 22. And the last one that you all also brought up was the SLUM, so the St. Louis University Mental Status Exam. And this is an 11-item questionnaire scaled on a 30-point scale, available in 14 different languages, and takes a little bit longer to administer, so 15 minutes. And it does take into account the education level. So that cutoff of individuals with a high school education or higher is going to be 27. And then those with a lower than a high school education is going to be 25. Now the slums just have less publishable data on it. And so that's just something to consider when considering which one you might pick. So once we gather all this information and we have the assessment, what can a behavioral health consultant do? So because teasing out of this information can be a lengthy process that's not available often in primary care, often BHCs are not making the diagnosis. Their main job is to kind of differentiate between the people who may need further assessment and then people who we can might be doing some behavioral intervention to see if it gets better. And so if you do your interview and you choose a screener and the results come up negative, it's good to advise your primary care provider to repeat that test in about 6 months, and either you or they can do that in order to see if it's stable or if there's been changes over time. Now, if you do have a positive screening result, this is when we can have conversations with the family and alert the possibility of a dementia process and really recommend that they seek further evaluation. So if we go back to this negative results and we think, hey, behavioral intervention is a good place to start here, we can talk with the patient and or the family about reminder devices. So these would be like calendars, alarms, sticky notes. We can talk to them about memory exercises, so puzzles, Sudoku, appropriate activity levels, different relaxation skills, because we know that stress can definitely impact the way that we think and encode information, lifestyle factors, resource connection, and then if we deem that something else is going on with their health that might be impacting their cognitive abilities, we can work on some of those things to clear that up. So moving on to the next bullet that was on our previous slide is elder abuse. Again, 1 in every 10 Americans 60 years or older experience at least one form of elder abuse. And often when we're thinking about elder abuse, we really have a keen ear for the first 3 on this slide. And the exploitation, neglect, and abandonment can be a little bit harder to identify, especially sometimes you can see caregivers or family members do this unintentionally, and they're trying to take care of their family members, such as cashing a check so their mother doesn't have to worry about it. And so it's good to just have a good ear about all 6 of these things. So, it's helpful to just recognize the different signs of elder abuse. So, any sudden changes in financial situation, if there's physical stuff going on, bed sores, poor hygiene, unusual weight gain or loss, if you're witnessing that the relationship is strained, even in your appointment, you're noticing any belittling or other types of physical concerns, such as bruises, broken bones, or burns. Or if you're noticing that maybe the patient is withdrawn or withdrawing from social interactions, it's a good idea just to look a little bit more and have your ear tuned to that. Some of the questions that a BHC can ask to help you get a good idea of what might be going on or the dynamics between the caregiver and the older adult is, do you feel uncomfortable around anyone in your family? Has anyone forced you to do something you do not want to do? And then the other questions that are on here. And if you do suspect that there is some type of elder abuse going on, making sure to check in with your PCP if they've noticed any signs that they're worried about, and keeping up to date with your state laws and what they have in terms of reportable age. And then call Adult Protect Services with any type of suspicion. Another thing that we can do in terms of just helping prevent elder abuse is really give some attention to the frustrated caregivers and helping them cope with some of the difficulties that are going on. And we'll talk a little bit more about that toward the end of our presentation. So if we slide into our next bullet point, the mental health in the older adults, again, 14% of adults 60 or older have a mental health concerns, but many of these other older adults have emotional or mental health concerns that are sub-threshold that still need to be addressed as well. And with being that most common is depression and anxiety, it's good to know that sometimes these concerns can be a reoccurrence from what was happening in their younger life, or something that has continued with them, that is continued them over time, or it may be related to some of the changes they're experiencing in their older adult life. Again, really important to assess suicide in this particular population. Another key note about this is that depression and anxiety can actually present differently in the older adult population. So, for example, with depression, you may hear more somatic symptoms versus emotional symptoms. And then with anxiety, often it can look similar to the individuals who do experience in young adulthood, but it can be more centered around age-related concerns such as their current health level, health, and their death and dying. So these are two screeners that can help you kind of identify some of the concerns that are going on with your geriatric depression or geriatric anxiety. The geriatric depression scale is available in a 5-question, a 15-question, and a 30-question survey. So depending on the amount of time that you have. However, it does not assess for somatic complaints. So that's something you may have to consider when you are assessing for geriatric depression. And then the geriatric anxiety scale is available in both 10 and 30 questions questionnaires. And the 30-question questionnaire looks at both all somatic, cognitive, and affective symptoms. So if someone is struggling with mental health concerns, we want them to get good treatment, so evidence-based treatment. So these are 3 particular evidence-based treatments that are particular for the older adult population. The first one is the problem-solving therapy, and this is very helpful with geriatric depression and can be modified with some cognitive those who are experiencing cognitive impairment in order to give more structure or less structure based on the individual's need. Often CBT, cognitive behavioral therapy, and interpersonal therapy cannot be delivered in a primary care context in its entirety of the protocol, but behavioral health consultants can use pieces of each therapy in their behavioral health consultation, such as teaching an individual relaxation, behavioral activation, or if there's some type of role transition going on, doing more interpersonal types of interventions. Now, the first therapy on here, problem-solving therapy, PST, has actually had a protocol designed specifically for primary care. And so we're going to actually spend our next couple of slides learning a little bit about PST for primary care. So problem-solving treatment for primary care was designed based on the original problem-solving therapy and developed by Oxford University. And basically what it's meant to do is to let patients and family members and caregivers gain problem-solving skills, valuable skills that they need to navigate their world and be flexible. And then other pieces that might be helpful in conjunction with this protocol is definitely psychoeducation about what is going on in the particular person's life, as well as behavioral activation, and then motivational interviewing about enacting the solution that they decide to do in the problem-solving treatment. So if we look closer into the differences between problem-solving treatment, primary care, and traditional problem-solving therapy, you can notice that actually anyone on the care team can deliver this treatment. It doesn't have to be necessarily a behavioral therapist. And this treatment for primary care is shorter, so 30 minutes or less, and takes less visits, so 4 to 6 versus the full 10 or more. Overall treatment actually is about a third of what a problem-solving therapy traditional treatment would be. And in the problem-solving treatment for primary care, all the skills are taught in the first visit, where in traditional problem-solving therapy, the skills are spread out and they learn them over time. So if we look a little deeper into the 7 stages of problem-solving treatment for primary care, the first stage is really defining the problem. So this is making sure that the problem is not vague, that it's doable. And so something like example like this, maybe an older adult says, okay, diabetes is my problem. Well, that's pretty vague because they can't get rid of diabetes. And so we want to talk about, okay, adhering to a recommended meal prep may be the problem, and that's much more specific. Also, when defining a problem, it's good to kind of assess if the problem has multiple layers. And so, for example, if someone comes in and says, hey, I have a really poor relationship with my spouse, and we look closer at it, and there's a couple of things that might be coming into play, such as I don't have any time with my spouse. They're spending way too much time at work. We don't agree on parenting strategies. Often they take their word of their mother over me. Then we would separate those concerns into separate problem-solving treatments and delve in. And so you might be doing 3 or 4 as you go along. So after you have clearly defined the problem, then you're going to establish a realistic goal. And so this is a behaviorally objective goal, so meaning that you can measure it. So did you do it or did you not? Having a clear idea of when it's been completed. Then the third stage of problem-solving treatment for primary care is generating multiple solutions and alternatives. And so this is the brainstorming time. And so all solutions are welcome, even magical thinking, even things that are not within the patient's control. This is just a brainstorming visit. Then after someone has kind of brainstormed all possible solutions, then we implement the decision-making guidelines. So you're going to go through all that brainstorms and cross off the ones that are unrealistic, not in the person's control, magical thinking. And then you may pick a couple or even all of them, decide to do a pros and cons list and see the cost benefit analysis and what other consequences might come from trying out the solution. Then based on the cost analysis, you're going to pick a solution to try out. The whole point of this is to experiment with some of one thing that you haven't been doing, and then evaluating it afterwards. And so you may design, okay, we're going to try this particular solution for 2 weeks or 3 weeks or a month. And then after they've tried that solution out, sorry, I skipped ahead. So stage 6 is actually putting in the preferred solution or solutions based on what they want to do. And then the last one is at the next visit when they are evaluating the outcome of the selected solution. So how'd it go? Did it go well? Were there any barriers? Do we need to tweak this or completely kind of drop it and go back to the original list to try something new? So we go to the last kind of bullet that was in our 4 things to touch on today. And I really want to talk about caregiver distress, because often older adults do have some type of help, some type of caregiver. And it's important to know that caregiving can happen at any age. So actually about 12 to 14% of caregivers are between the age of 18 and 24. And about 2/3 of that population holds full-time jobs in addition to taking care of their particular individual or loved one. We also know that about 44% of caregivers are 2 times below the national poverty line, and so they're dealing with financial struggles as well. And this particular caregiver population, over half of them reported that they had a decline in their own health due to additional responsibilities of caregiving that they haven't been able to take care of themselves as well. So when we think about all the things that a caregiver has to do, they really have to be really good problem solvers, right? They have to navigate the resources, they have to navigate a system that we know is impacted by ageism, and so they have to be patient advocates. They have to try and make someone adhere to the treatment recommendations, and we all know how hard sometimes it can get someone to do something that they don't want to do. And they have to coordinate not only in clinic care, but outside clinic care and be aware of those resources. So what can we do as BHCs for the caregiver population? Education is key. Knowledge is power. And so being able to provide the patient as well as the caregiver some understanding of the characteristics, the causes, the trajectory, what they should be expecting on that particular patient's health concern. So they're able to kind of put things in context as well as advocate for the things that the person that they're caring for needs. We can give them available resources. We can talk about how the caregiving needs of can actually impact the family system. Right? It's not, I know very often when I'm talking to a caregiver, it has impacted siblings relationships because people are more involved than others. And also figuring out how to and what to expect in the care supports teams and the healthcare and the social settings and housing around this. Now, caregiving, if I haven't made the case already, it can be very difficult and emotionally taxing. Taking care of yourself, taking care of someone else, trying to make sure that they take care of their health, but also they may have a lot of things going on for themselves. And sometimes, that relationship between the caregiver and the person being cared for wasn't great. And now they're having to do a lot of responsibilities and related to this person. And so what we can do for caregivers is we can connect them with, support groups, people in similar roles, so they can trade stories or solutions or support one another. We can help them with, expressing emotions and their tolerance around some of the frustrations that may come from caregiving. We can enhance some of the same coping strategies with sadness or grief or fear or anger or guilt, right? They are also witnessing the person that they're caring for, their changings in functioning, and that could be really hard for a family member. We can also help kind of through education, help them empathize and with the current patient's experience and interact with them differently. For example, for caregivers who are taking care of someone with dementia, right? Encouraging them not to challenge, correct, or say remember, but it instead distract and redirect and practice remembrance. And then also helping caregivers develop positive meaning behind their caregiving activities. There's been literature out there that individuals that have positive meaning in how they're taking care of their individuals actually ward against caregiver burden. And then finally, we can help our caregivers with skill development. So we can talk to them about how to elicit support either from family members or their healthcare system. We can enhance those problem-solving skills that they're definitely going to need in navigating multiple areas within the caregiving process. We can also talk with them a little bit about how they can use technology to help relieve some of the responsibilities that they might be doing. So setting alarms, online support groups. If there's a particular physical need, such as someone needs to be lifting someone or doing a certain transfer, we can connect them with classes, how to do that safely and give them the information in order to help that family member do the tasks that they need to. And then we can talk to them about, having a future-oriented mind. So getting ready for maybe some of the legal documents that have to come into play. So medical power of attorney and other things that might be very hard discussions. So when we're looking about serving the older adult population, in general. These are just some key take homes that you can do in your visit. So if a patient does bring in a caregiver or a family member with permission, just considering the source of the referral. So understanding and having a clear picture who's supporting who. There might be some ways that, yes, the family member is supporting the patient, but the patient may also be supporting the family member in different ways. So getting a clear picture of the context of what's going on. Making sure that we're building rapport with the patient and the family, right? So making the patient the center of the conversation, allowing them to answer first, and then asking permission if we can consult with the collateral information from family members or caregivers. And then sometimes, some older adults don't really have a lot of experience with behavioral health assessment and treatment, especially with this idea of that behavioral health consultants can help with more than just mental health concerns. And so education can be helpful. And often with that education, a lot of older adults are receptive to behavioral health treatment. It's always good to assess patients' ability to share history and also understand that you might have to have a greater reliance on collateral information if there is cognitive changes. And again, understanding when those changes occurred. Has it been gradual or has it been something that's been late and just started? And then sometimes, people have been flying under the radar. And what I mean about that is that they may have been coupled with someone who was doing a lot of the caregiving responsibilities. For example, if a spouse has just recently died or someone else has stepped out of that position, that particular patient's needs may have become amplified because no one is there to kind of moderate those effects. And so understanding that context around that. And then, of course, making adjustments specific for patient needs. So adjusting volumes or rate or speech, having larger print materials for screeners or handouts, and then having seating for potential caregivers. Of course, we want to do this again. We want to individualize it because just a global acceptance of some of these additions may actually contribute to ageism in the healthcare. And so I've gone over a good didactic portion for you all. And so I just have a quick case. And feel free to unmute or chat at the end of this case. So Martha, a 75-year-old Hispanic Spanish speaking patient, came to you with the presenting concern of memory issues. Her daughter reports that over the past year, she has noticed that her mother has been more forgetful, often unable to find her keys and walking into a room and not remembering what she went there for. Just recently, the family has been more concerned that Martha is doubling her medication because she is not sure if she has already taken them. The family is increasingly worried because she is spending more time in her room, which is unlike her, and notices that she appears more sad, paranoid, and worried. Martha denied that she is experiencing any of these problems and is saying that her family is overly concerned. Martha's daughter is in tears, feels overwhelmed, and states, I just don't know what to do anymore with her, and I'm not getting any help from my sisters. What are some of the things as a BHC you might be able to do for Martha and her family?
Can we just talk?
Yes, that's perfect.
Okay, well, that Martha case looks like me, but I don't have any sisters or anybody. So what I have done is because my mom recently got her Medicaid, so I look for a provider.
Mhm.
So this is because my brother is gonna be soon here, so from Venezuela, so he will help me a little bit more because everything that you're saying over there is happening. I mean, it's overwhelming because I
Yes,
have a job, I cannot do what I was used to do before, and then she
yes.
want me to take her to church and this and that, and I can't. I mean, it's my time is really, really, literally nothing for me.
Yeah,
So
yeah,
it is overwhelming
yeah. So
and
we
it is bad. I mean, so that's the only thing that I have been able to do.
Yeah, so definitely talking, and I'm glad that you did this as well, talking with your family members about how to ask for support. So it sounds like you're getting your brother involved. So that's definitely something we can talk about with families as a behavioral health consultant. Thank you for unmuting and sharing.
No
And
problem.
then in the chat, we have Stacy's support to the daughter, problem solving for taking medication, planners, med packs, pill dispensers. Wonderful. All great ideas. Anyone else?
I I can say something. I had this happen with a patient, but she was Arabic.
Mm-hmm.
Her son came in, and her son's been doing, the one son that's in America with her has been doing all the caregiving. She's going to have a brain scan. She's on a bunch of medication. She's really depressed. She's probably got post-traumatic stress from the past. And he was saying that he was going to maybe send her back to her home country so that his brothers could have some time with her. But she doesn't want to go. She's really lost interest in everything. And I think there's post-traumatic stress. But what I did was I printed out a whole dementia guide in Arabic to give to the son to read to her so that he could at least get a idea of how to plan for the future for her. It's really difficult when there is a language barrier on top of cognitive, problems. So
Yeah. Well, thank you for searching that. Education is an intervention for
yeah.
sure. Thank you. Anyone else think about what we can do for this family? All right. Well, we can definitely give them a cognitive screen. We can definitely talk about problem solve different ways around the medication use. We can look at how to really address some of those personality changes, as well as giving support to the daughter about what's going on and providing education if we are concerned about that, about a potential diagnosis of dementia. So in summary, what I'm hoping you took away from this presentation today is that BHC integration benefits the older adult population and their families and the primary care setting in general. It can reduce a lot of barriers to the help that they need, that providing education and teaching problem solving skills is helpful for the entire family unit, and you can generalize that information and skills over different contexts, and that BHCs really do need to be aware of age-specific concerns when they are helping this population. And they can come in a family medicine clinic. They can come in a specific geriatric primary care. And so just being aware or knowing where to find that information is important. So you made it. Thank you for sticking with me. I know it's the holiday season, and so now
Los pantalones.
sorry. And now we'll transition into
No,
the
yo te hice,
question
¿tú crees que
and
te hiciera?
answer.
Well, thank you so much, Dr. Houston, for such a great presentation. It was so well organized and insightful. So we really appreciate that you took the time to, do this presentation, like you said, during the holiday season. Thank you all so much for joining us today. And as you know, the follow-up to this will be an email including Dr. Houston's slides, a recording of the presentation, as well as the link to the evaluation survey. So you just need to fill out that survey in order to get your certificate of attendance, which will count towards CEUs. So just keep an eye out for that email. But if anyone doesn't have any, we have Dara with a question. So yeah, we can open it up for questions now.
Sorry, I know we're out of time,
No,
but
you're fine.
Thank you. This was very helpful, and I'd love to get your email address to talk to you more. I was curious with the problem-solving module that's specific for primary care. Is there a place that certifies or trains people in that model, or resources that you have, like workbooks or materials?
Yeah, I'm not exactly sure if there's a place, but I know particularly there's a handout that actually discusses the problem-solving treatment for primary care. And I'm gonna unblur my screen so you can see this book. But in the integrated behavioral health
Yeah,
in primary care, they actually have a section of problem-solving treatment for
they
primary
do.
care.
Okay.
And it's a handout, and you can just go through that handout with your patients. Unfortunately, it is only in English, and so I'm not aware of other handouts that are provided in other languages, but yet I haven't Googled it either.
Okay. And then my other question is, have you found particular group models more effective for seniors, or evidence-based for seniors?
I don't have much experience in group models.
Okay.
That would be something I'd have to look into. I think that, definitely support groups for caregivers has been very effective. And I know that often when we talk about, getting older adults out there, it is about connecting with other individuals and keeping them active. So I would suspect that it might be helpful, but I don't have the evidence behind that.
Thank you.
Great questions. And I'm sorry, I thought we had till 1:30 today.
You do have until 1:30, so that's why if anyone else has any questions, like please feel free.
I've heard that blue book, they're coming out with a new edition in January.
They are, and they're accepting pre-orders right now, and there's a 25% off coupon floating out there.
Oh, that's good to know.
So I would highly recommend. I have the 2 books before, and when I was first in primary care, I kept that in my car and read a chapter every day before I went in.
Do we have any other questions or even just comments, thoughts?
I mean, in my experience in the hospital setting that I'm working in, this is a growing population, and they are trying to put more support with coordinate. Like, they just built us a building where all the geriatric services are in the same house. So we have neurology, neuropsych, memory and aging, falls clinic. And one of the things that I'm being tasked with is I'm the only psychologist who serves this large clinic.
Mm.
And so they're hoping to kind of do the PCBH model of warm handoffs. And so I'm just wondering, if you've had experience just being a person of one and not having a full PCBH team, what's been effective for you?
Yeah, so I am a BHC of 1 in my organization. I do have a social worker that works with me as well, but we're never there on the same days. And so it just depends. I mean, in a new PCBH service or anything like that, if they're particularly wanting you to work on memory concerns, you may explore pathways. So identifying specific criteria that would automatically give you a referral. So again, when you're thinking about maybe you're thinking about, addressing depression and anxiety too, maybe you do use the geriatric scale that's just a 5 geriatric depression scale that's just a 5 questionnaire, and then figure out a cutoff where there's an automatic referral to you. Or even if you're saying, okay, if you're noticing any of these warning signs, I can do the first part of this. I think because you have so many resources, it might be helpful to get together with the particular groups that do the more in-depth evaluations and say, what would you like me to do in primary care before I refer that to you? So Dr. Stacy Obai down at UT Health San Antonio, they have actually done a memory concerns protocol for primary care where I think it's about 3 or 4 visits, where the first one they do just a normal behavioral health consultation appointment, and then they do a screener, so a MOCA or a Rudos or a slums. And then in a subsequent visit, they do the TOMS to see about malingering. And then they do a second, like, I'm not sure if it's from the WIMS or the, but it's a section of a bigger battery that their neurologist asked them to do in order to kind of assess what's going on to see if there needs to be further evaluation. So I would really encourage you to kind of just chat with the other services and see if you can develop something that might just be encompassed in 2 or 3 visits that you can break up over time.
And are those billable under assessment codes or HMB codes, or do you know how they get reimbursed for that?
Yeah, I'm not sure.
Okay. What did you say the university, or what is that out of?
University of Texas, UT Health at San Antonio, Dr. Stacey Abide. And I don't believe that she's published on it, but I know that she has presented on it at conferences.
University of Health at Texas, you said?
University Texas, well, it's called UT Health. So University of Texas Health at San Antonio.
Health at, okay, perfect.
And she's actually our faculty lead on the behavioral health consultant course that is.
Yeah, she's done some of these echoes as well, and I've read a lot of her stuff.
Yeah.
Okay, so this protocol is unpublished, you said?
I believe so. I checked
Okay.
in with one of her colleagues and they said that they had not written on it.
I can include her email in the her email address in the follow-up email for you to be able to contact her if you'd like. She's usually very responsive despite how busy she is.
Okay, yeah, that would be helpful. And can I get Dr. Houston's as
Yeah.
well?
Of course.
Of course, of course. And then I see Beth in the chat. Are there any new specific resources or ideas about elderly housing? I'm not aware of that, but I know one particular search engine that I have found helpful in the past is findhelp.com, and just typing in things, and often that can bring up a lot of resources.
Do we have any other questions or comments?
Do you have any resources on convincing providers to, like, right now I've been integrated into the primary care setting, but kind of transitioning to a more short-term model or the flow. Like, one of our challenges has been the flow of warm handoffs with spacing, and when they have like medical trainees or residents with them, and it just, things getting delayed. Like, do you have resources of how to kind of get the buy-in of the providers you're working with to do same day or warm handoffs?
Yeah, it's really hard just because, like you said, establishing a kind of a flow, and especially in a residency clinic, I'm your attendings are going to be your best friends, really getting them to bring it up quite often. And then often I've heard recommendations about, when you're first doing this, do nothing but warm handoffs, so that you can make a culture of warm handoffs, or have them shadow you, you shadow them, and let them know, what you can do with each person on their panel. I think it's really hard, especially because they are so busy. But definitely spreading out your appointments, considering on the busyness of the clinic, and maybe lumping your appointments when it's less busy and having more slots when it's not so busy, and then being okay with running behind and taking warm handoffs as they come. It's so hard because, it's getting started is hard, but once you start doing good work, people will start, bringing it to you. And if, patients are saying it and it's quick and easy, and then it'll pick up. But often when you're starting a new PCBH services, it can take up to 3 years to really get going and change the culture.
That's good to know. Thank you.
Great question.
I just had another, sorry.
Yeah, I'm here.
In terms of memory, like I am kind of struggling with patients that I've had who originally did not have the dementia diagnosis and have declined over time. Like I'm trying to figure out like when to terminate services or how to judge that this is no longer effective for the patient, especially, I mean, they're often bringing family members with them, but I have to reorient them to who I am.
Right.
And so I'm not sure like ethically when to terminate services based on their dementia or cognitive decline. Do you have
Yeah,
thoughts
it's a
on that?
Yeah, it's a hard question to answer. I actually just had a visit with someone like this the other day. And the first thing that I did was consult the provider and understanding when they thought it would be kind of counterproductive and almost frustrating for the patient. So, for example, this particular patient was in stage 6A, which I didn't even know there were stages of dementia, which is like severe to moderate to severe. And, she couldn't answer any of the questions. She got nervous when she was answering the question. She wouldn't remember anything that I was saying. And so there wouldn't be much follow through. And so that's really clinical judgment around like, there's no progression here. And at this
Yeah,
point, all I can do is support the caregiver.
right. Definitely. Okay, thank you.
All right, y'all. Sounds like we're at the end of the questions. I'll definitely give you a PDF of my presentation and I'll send out my email. I'm happy to answer any questions. Thank you for doing good work.
Thank you so much, Dr. Houston. Thank you all for sticking around. I will send out that follow-up email shortly. So I think that's it. Thank you so much. Have a good day. Thank you, Dr. Houston.